Welcome everyone to today's webinar. I'm Layla, the Community Engagement Coordinator for the Canadian Cancer Survivor Network. Thank you for attending the webinar, Nutrition and Surveillance Counseling for Cancer Survivors. We are pleased to welcome today's presenter, Dr. Paul Rogers. He is a clinical professor in pediatric oncology, hematology, and BMT at the University of British Columbia and BC Children's Hospital. For the past 30 years, Dr. Rogers has worked in tertiary university-affiliated hospitals with clinical, teaching, research, and administrative responsibilities. He is the former head of the Division of Pediatric Oncology, Hematology, BMT at BC Children's Hospital in UBC. He has also been a principal investigator with the Children's Cancer Study Group, now known as the Children's Oncology Group. He was a member of the Canadian Partners Against Cancer Advisory Council. He also served as the co-chair of the Canadian National Task Force for Adolescent and Young Adults with Cancer. He was a local chair for the SIOP Congress in Vancouver in 2005, and he has also served 6 years on the SIOP Scientific Committee and has served as the Secretary General on that board. During today's presentation, Dr. Rogers will talk about nutrition from a cancer control perspective, the importance of continuous longitudinal nutritional assessment from diagnosis through survivorship, the role of nutrition on the well-being of cancer survivors and chronic disease prevention, and incorporating nutritional research and survivorship research, among other topics. At the end of the presentation, he will be able to answer your questions. However, at any time during the webinar, please feel free to type your questions in the window in your control panel. For those of you who have not attended an earlier webinar, the Canadian Cancer Survivor Network is an organization working with cancer patients and survivors to learn about health system complexities, connect with others to plan action, and act to promote best care and healthier survivorship. If you'd like to learn more about CCSN, please visit our website at survivornet.ca. This webinar is being recorded and it will be available tomorrow on YouTube. In addition, the slides will be available on SlideShare and links to both will be sent to the email you provided. I will now welcome our presenter. Welcome, Dr. Rogers.
Thank you. I don't profess to be a nutritionist, but I do profess to being so interested in nutrition that I think it is under-researched, both during treatment as causes of cancer and especially in long-term surveillance of survivors of cancer. This presentation was initially given at the CEOP conference last year on, again, a Zoom type conference. And it is aimed predominantly at survivors of childhood and adolescent survivors, but it is equally relevant, what I'm going to say, to survivors of adult cancers. So do not feel that this is entirely specific to survivors of childhood and adolescent cancers. So, moving on. Fuck. I can't move my slide. Survivors. This is a group of young adolescent and young adult patients who are off treatment. In Vancouver, we are sponsored to hold 4 adventure camps for our survivors for a number of reasons. One, to put them in touch with each other so they can bond. 2, to help them gain confidence for the future. And 3, to give some guidance and education. From this perspective, I went as the medical officer on this tall ship cruise, which was a 5-day cruise around the Gulf Islands near Victoria, where they learned sailing techniques and how to tie knots and many other aspects of seamanship. And during this period, I was able to undertake interviews with this group around nutrition, about their knowledge of nutrition, and what was their general intake in their diet. And unfortunately, it was surprisingly awful. And this cartoon essentially depicts their minimal knowledge of what these survivors had. And unfortunately, it probably depicts the knowledge of many people in the general public have of nutrition, where it's just assumed something that you do every day to survive. So unfortunately, knowledge is poor. So what are my objectives of this talk? Well, I want to try and tell you that nutrition plays a fundamental part in cancer control. And I'll talk more about what cancer control means shortly. I also want to continuously say that ongoing longitudinal nutritional assessment, which should be specific, should commence from the diagnosis of your cancer right through continuing through survivorship, because it's fundamental to your well-being. I will talk about what is known as the ABCDs of an adequate nutritional assessment, the role of nutrition in the well-being of cancer survivors, the importance that nutrition may play in cancer prevention and other chronic disease prevention, the importance that you do require counseling for good nutrition and to help your quality of life, that research in nutrition in cancer is absolutely atrocious. It is minimal, and especially minimal in survivorship research, and this should be incorporated into long-term follow-up. And as an indicated cancer control perspective, nutrition is a modifiable prognostic factor that is independent of the cancer and the treatment given. So cancer control and nutrition. Cancer control has different meanings to different people. Some people think it's about prevention. Others just feel it's a sort of national strategy, of which it is. But these components that I have listed on the slide really embrace the whole of the cancer journey, from prevention through to palliative care. Nutrition plays a role in the epidemiology of cancers, how the cancers themselves develop with respect to the biology. There's some aspects of therapy that are now being utilized of the actual treatment of cancer. Obviously, supportive care when you have inadequate intake is very important. Certain toxicities may occur because of a lack of specific micronutrients. The psychology, good adequate nutrition does associate with a better feeling of well-being. The delayed effects into survivorship are important and can be sometimes ameliorated by adequate nutrition, and even in palliative care, how to feed the patient appropriately without being invasive in the palliative care stage is also important. So what are the things that we need to talk about with respect to nutritional surveillance, education, and counseling? With respect to the first world high-income countries, obesity is a scourge. And it's something both for cancer as well as other chronic diseases that we need to be far more cognizant of, be both preventive and more aggressively treat. Underweight is the other end of the malnutrition spectrum. Patients can become underweight both because of their cancer as well as because of the side effects of various treatments. Both obesity and underweight being that can affect your quality of life. We do need to also consider the long-term sequelae of disease and its treatment, and that can be affected by nutrition as well. And again, reiterating the importance of prevention. So what do nutritional deficiencies, insufficiency, or excess calorie cause pathologies? Obviously, in children, growth stunting and cognitive impairment is important. What makes pediatric and adolescents and young adults different is that they are still growing. Your frontal lobe, for example, doesn't really reach adequate maturity until at least the age of 25. All of these things can be affected by either deficiencies, insufficiencies, and or excess calories. Impaired physiology. If you don't have the right nutrition, your physiology, how your body works, your metabolism can be impaired. Specific organ dysfunction. I'll use the liver as an example. Your liver is the factory of your body. It's where you make many of your proteins and do many of your detoxifications of your liver. And inappropriate and especially excess calories can lead to a fatty liver. And this is directly due to the type. This is different from alcohol-induced fatty liver. This is because of inappropriate diet. Your immunity, you do not have adequate immunity against infections unless you are appropriately nourished. Many of the micronutrients and even the protein that you intake is necessary for you to have an adequate immunity and to fight off infections. Micronutrients is an under researched, under assessed aspect of survivorship. There are specific pathologies that are associated with micronutrient deficiencies. Probably vitamin D is the best known, associated with thinning of the bones, osteoporosis, as well as in children, the severe side of the deficiency is rickets. Obesity and comorbidities of other diseases. In obesity, it is frequently found that obese patients are micronutrient depleted while appearing to have adequate nutrition. So what is an adequate nutritional assessment? Weight alone is not enough. We should be following a long-term follow-up clinics and your long-term doctors. Many of them need to be trained in nutritional assessment. And these are known as the ABCDs of assessment. Anthropometric, what does that mean? That means measurements, height, weight, and I'll go through all the rest of them at the moment. Biochemical, what you can do in the lab, assessing your nutritional status. Clinical, it is still essential, good old-fashioned examining of the patient and looking for clinical aspects, the signs in your hair, skin, etc., that you can be examined for. And dietary, where the dietitian is so important. Actually evaluating what is your intake. Are you getting enough protein, calories, and appropriate micronutrients? So in the anthropometric measurements, we have height and weight. Very important in children and adolescents to look at combining the height and weight to develop the BMI. And all adults, BMI is now a very useful indicator of overall nutritional assessment, but it has its flaws. Somebody who's very muscular may have a high BMI, but they have a small amount of fat, and that's not bad. But generally, it is an indicator of whether you are overweight or obese. In adults, waist circumference is very important. Waist circumference, in fact, is more important than weight. And there are many graphs that will show your waist circumference on the graph, as well as your waist height ratio. Underused, but should be used more, is your mid-upper arm circumference, MUAC, which is taken with a standard tape measure. And there are many graphs as well that will give you an assessment of muscle by the MUAC as well as of fat. Specifically, though, for fat is the TSF, which stands for the triceps skin fold. That sort of bag of fat that you have at the back of your arm is your TSF, and that is more specific for measuring fat. The very sophisticated anthropometric measurements are due to the Dexa scan, which is a radiological measurement that can assess the percentage of fat, muscle, and can assess bone density. This is used frequently for bone density in menopausal women to look at the degree of osteoporosis that they may have, but it can equally be calibrated to assess whether you have an increased percentage fat or decreased percentage muscle. Bioelectrical impedance is a very simple scale that sends up a small little electrical pulse through your body and can assess the percentage of fat. And it is useful to look at when you're over a longitudinal period, when you're going for follow-up, how much your percentage fat is changing. It also has its faults and can be impaired by your hydration status. CT scans, which many people who have cancer obviously have a lot of CAT scans or MRIs, and these can be calibrated as well to assess your percentage fat as well as your percentage muscle. So these are sophisticated ones and are used more in research capacities, but the Dexa scan is becoming much more in common use in follow-up. So the biochemical, the blood tests, looking at the specific protein in your blood, serum albumin and serum prealbumin. These are good indicators of what your nutritional status is, but does have the flaws of being affected by a number of other comorbidities, such as infection, overhydration, what your kidney or liver function is, whether you have decreased making of protein. So, but it is still a help in assessing your nutritional status, especially when you're on treatment. And then in capitals here, specific vitamin and mineral levels. I'm a big ardent fan of assessing micronutrients, and these are best assessed by doing a biochemical study, but they can still also be evaluated clinically. Clinical, the good old-fashioned physical examination, both by your doctor or your nurse practitioner or nurse clinician, looking at signs of protein or calorie deficit. I grew up in Africa, where obviously malnutrition is predominant. And when I was at medical school, we saw two things that were awful to experience. One was called kwashiorkor. And kwashiorkor is where they look like fat little cherub babies. And they're called sugar babies because they're given excess sugar, but no protein. And they have a tremendous amount of problems because of having low protein mass. And if they have a combination of low protein and calorie, we call that marasmus, the skinny, emaciated children that you frequently see on adverts on the television. And just examining for micronutrient, you can see changes in color and density of the hair by looking at it properly. On the skin, you get a multitude of different kinds of rashes due to deficiencies of micronutrients. For example, certain of the vitamin Bs will give you what's called pellagra. You will see in severe vitamin C deficiency the signs of scurvy. These are all things that we should be looked for. Around the mouth, in the mouth, the tongue can show definite signs of iron deficiency with what's called a bright red tongue. As you can see also in vitamin B12, you can get cracking of the lips around the side, which is also associated with vitamin B deficiencies. In the eyes, vitamin A is very important. It's a major cause of blindness in low-income countries, where you get what's called xerothermia, which is a sort of cloudiness of the eyes, which can be ameliorated by vitamin A substitution. And then bones, vitamin D, calcium, magnesium, these are all important for bone growth and bone hardness. And vitamin D is a big problem in northern countries. So these are just the clinical aspects of nutritional assessment. Then we have the dietary aspects. This is where having a registered dietitian in your clinic makes a big difference, but still can be done relatively superficially by both the doctor and the you need to know what the macro intake, the amount of calories you get, and the amount of protein. And there is a standard little formula. For example, you need approximately 2 grams of protein per kilogram of weight. But what's important is assessing not too little or too much calories. Both ends of the spectrum of malnutrition, too much and too little. And then you can assess the micronutrients. Is their diet just meat and potatoes? Or is there anything else in it? So trying to evaluate the micronutrient intake, best, as I said, done by a dietitian. And there, taking at appropriate dietary history. You can do what's called a 24-hour history and inquire what did they actually eat over the last 24 hours, or you can do a week history, which is much more valuable to get an assessment. And there are now many computer programs that if you pump in what the patients have actually received, you can develop what's called your healthy eating index, which ranges from 100 to 0. Therefore, by using a nutritional diary, you can identify people who are at risk of both ends of that malnutrition spectrum. And reiterating, if you can get your clinic to get a registered dietitian attached, all the better. So this is from an amalgamation of articles, Zhang and Cohen at the bottom there. But just as a review, 80% of young cancer survivors have an inadequate take of fruit and vegetables. And this goes on into later adulthood as well. 50% in North America have an excess energy intake in high-income countries. 95% have inadequate vitamin D intake. We can also see a number of deficiencies in these other micronutrients, which are essential for your physiological well-being. Iodine, for example, you can't function your thyroid without adequate iodine. Selenium is something that may be associated with increased cardiac toxicity. And unfortunately, Poor dietary habits in childhood and adolescence continue in adulthood and through adulthood. And therefore, we see these low healthy eating indexes. Sometimes we doctors get stuck for definitions and like to box things. And we just look at the one end of the spectrum and the other end of the spectrum. But it is a spectrum from deficiency, where you can actually see the clinical signs that I alluded to, like in rickets, where you see widening of the bones at the end of your wrist. You can see what's called a rickety rosy on your ribs. That's when there is obviously clinical deficiency of vitamin D. To insufficiency, where there are no clinical signs, but the laboratory result comes back below normal for that age. And this may impair, especially, again, your bone health, as well as your immune function. And therefore, into optimal, what is optimal? But these ranges are controversial. This is just a sort of slide indicating the difference between deficiency, insufficiency, optimal. And one's also recognized that there can be overdosage. Often people consider vitamins safe, but overdosage can be bad and can cause problems in themselves. For example, in vitamin D, if you take too much vitamin D, and there are many sort of articles that are sort of promoting high dose vitamin D, it can lead to increased of calcium uptake, increased damage to your arteries because of calcium, and probably the most common one is the resulting of calcium renal stones. So it's to indicate that micronutrients can be overdosed as well. Just looking at this worldwide as a national health problem, if you take 50 nanomoles, which is in the insufficient range, it has been estimated that over 1 billion people are vitamin deficient or insufficient, resulting in all the metabolic and physiological problems that its insufficiency may result in. It is to recognize that we in Canada, we live above the 49th parallel. And so just the normal population, many patients, many normal, otherwise people without underlying diseases are found to be vitamin D depleted because we don't get sun in the winter. And it is something that probably is a national healthcare concern. So again, for high income countries like we are in Canada, there is a bad prevalence, increased number of patients who are both overweight and more severely obese. And of the childhood cancer survivors who have become adults, 40 to 50% of them are overweight. We see what is called sarcopenic obesity. And that means that somebody may look adequately nourished. They may look a little chubby, but that is because they have excess fat and very little lean muscle. And sarcopenia means low muscle. So your patients are obese because of the fat, but they're inadequately nourished because of lack of muscle. There's an increased prevalence of adult cancer in obese patients, and there unfortunately there are poorer prognosis of adult patients who have cancer. So obesity, it's not only cancer, but in survivorship, the importance of recognizing the other comorbidities that can occur for numerous reasons, but one of them can be from previous treatment received during cancer, as well as excess intake of calories. So we have the cardiovascular, the increased risk of coronary artery syndrome. We have the metabolic syndrome, which is defined as an increased blood sugar, hypertension, visceral fat, that is the fat that surrounds your organs inside your abdomen. So you have fat around your pancreas and your liver and your spleen and your gut. And that also can result in increased cholesterol with all its risks of cardiovascular disease, and the continuous increased blood sugar will eventually impair into type 2 diabetes. Along with that, being overweight does decrease your quality of life, can lead to depression and anxiety. And unfortunately, obesity in childhood and adolescence is the strongest predictor of obesity in adulthood. Just again, looking at some pediatric statistics, we have now shown that in acute lymphoblastic leukemia, which is the most common cancer that we see in childhood, and using just a BMI as an indicator of being overweight, it's significantly associated with a poorer event-free survival. All those arrows on the right show the excess amount of death over the normal value for patients who are obese. And there at the bottom, you can say there is a 35% reduction of event-free survival of patients. That means staying in remission with acute lymphoblastic leukemia, therefore indicating it is a modifiable prognostic, independent modifier of prognosis over and above the treatment. So we need to look at prevention much more about nutrition helping prevent a number of different diseases. Obviously is the cancer prevention, and I'll go into that a little bit more. Chronic disease prevention, the other chronic diseases of adulthood, especially cardiovascular disease, which still is the #1 killer of adults in Canada and North America. And we can think of two aspects of prevention, both primary prevention and secondary prevention. So why do we consider diet? This is a study done back in 1981. Doll and Peter are very well-known, famous statisticians who did a lot of work in the UK. And as you can see on the right, if you just take eating, 35% of adult cancer was attributed to diet alone. Another, at least a third, if not more, is to smoking. So just by adequate prevention with diet and eliminating smoking, 2/3 of adult cancers could possibly be prevented. And these are the selected cancers that are related to dietary factors. Breast cancer, 33 to 50, prostate, and then all the important gastrointestinal cancer, stomach, and very much so colorectal cancers. So again, 30 to 40% of adult cancers can be attributed to dietary factors. So what can we do about primary prevention by using nutrition? Obviously, I've spoken about it frequently already. You want to prevent obesity. You want to prevent obesity right from childhood. It's sometimes often too late to do it in adulthood, but it's better to try than not. The prevention of obesity can lead to that optimal physiological health, where your body physiologically, metabolically is in the best status as can to support you in your everyday life. And again, the optimal macro and micronutrients intake. We should be paying attention to this because we can prevent these both cancers as well as other diseases by looking on preventing obesity and obtaining optimal physiological health. Obviously, if you are obese, it's the treatment of obesity. And this is extremely hard. All these adverts that you see on TV, trying to get different types of diets, it's very hard to treat obesity, but it needs to be done, and it needs to be done within the care of doctors and nurses as well. I'm going to go a little bit into science now and the influence of nutrition on epigenetic changes. Your genes, we know that cancer is probably a genetic dysregulation, but that regulation can be affected by nutrition. And I'll talk about what's called bioactive foods. So we now know what is called nutrigenomics and nutrigenetics. This is how your genes can affect what you do with your food. And it also, on the other end of it, what food can do to your genes. So with respect to persona, your body, like for example, people metabolize coffee differently, or the drug codeine differently based on their genes. But genes can also be regulated by the type of diet that you take in. This is a complicated slide, but I'm just talking about bioactive food components. There are over 30,000 bioactive food components in vegetables themselves, what are known as phytochemicals. And they have an impact on this nutrigenomics, nutrigenetics aspect that I showed in the previous slide. Neutrophil epigenetics is becoming more important. How the genes can be regulated by food substances, especially your RNA. And how it eventually, for proteomics is the study of proteins, and metabolomics is the study of the metabolites that are affected by your active food substance. And this ends up in what's affecting the phenotype. The phenotype can either be you as a person, you are the end result of your nutrition, or it can be the phenotype of your cancer and how these different components within this nutrigenomic spectrum is affected by nutrition. So as I said, cancer is considered to be, in many cases, disruption of gene function, where you get DNA mutations and gene deletions, chromosomal rearrangements, like is seen in chronic myeloid leukemia, with the genetic alterations within the cancer itself. But on top of that, and epi means above that that can affect the DNA is how it functions. The gene function is epigenetics. And these are what are called methyl groups that affect how the DNA actually functions. So these mechanisms of methylation are aberrant, are wrong in many cancers, and are resulting in the formation of that phenotype of that cancers. We know that these disturbances in methylation can begin very early in the period from gestation, from conception, through gestation, through childhood, through adulthood, and onwards. So I'm a big proponent that if you're really going to start prevention, we should be looking at prevention from the time of conception. Folic acid is a very important DNA methylator. And this is why it is so important during pregnancy. One of the many reasons that folate should be substituted or have a very adequate diet in fruit and vegetables. And that folate depletion can modulate gene methylation levels. This is a study that was done in children that looked at a meta-analysis. That's when you take an evaluation of a number of different studies that seem to have valid science behind them. 7 studies were looked at of parents, of mothers who had adequate diets or folic acid substitution during pregnancy. And this is a preventative active. As you can see, there was a reduction of 47% in the bioprotective effect for neuroblastoma, 39% for leukemia, and 27% for CNS tumors. This is a preventative aspect of nutrition that should happen from conception. This is a very good, sophisticated mouse study of 2 similar type of mice, not mouses. One, the yellow mouse, which is same as the agouti mouse, but the yellow mouse is very high at risk for cancer, diabetes, and obesity, and has a reduced lifespan. But if those mothers of that type of mouse receive maternal supplements of these 5 agents in the middle that are associated with methylation, you end up with a hypermethylated mouse, which is at a lower risk of cancer and obesity and prolonged life. And you can see it even affects the color of their skin hair. So epigenetics relationship, an old saying, I'm not really sure where this originates. You are what you eat. Many people say that, comes back from back from the Greek periods, and what we now recognize, you are also what your mother ate. So that was about primary prevention, epigenetics, how diet can influence genes, how diet can upregulate and downregulate the oncogenes and the ones that are associated with cancers. But we can also do secondary prevention, and this really relates to screening. Very important at any time to take an appropriate family history of cancers, which can indicate whether you should be screened. For example, colorectal cancers, which now colonoscopies is common for most people over the age of 50 and is a very important screening device, and especially if there is the history of colorectal cancers and or polyps in your large bowel. Again, going back to what your diet history was. Does this place a survivor at risk for cancer and other chronic diseases? Is the patient just a meat and potatoes person? Is there a high intake of processed foods? Is there a high intake of red meat? These are all things that may be associated with an increased risk and warrant screening. Again, I refer to the importance of vitamin D and the micronutrient intake and trying to prevent osteoporosis and osteopenia, and many of the other risk factors related to secondary malignancies. In a long-term follow-up clinic, this has to be considered and should be part of the long-term follow-up clinic. So back to our survivors. Here are my 17 survivors on the tall ship. And as I say, the nutritional inquiry that I undertook showed an appalling knowledge of appropriate nutrition, and their average diet was fast food. So what nutritional counseling are survivors? But it's not just nutritional counseling. Survivors need counseling in a lot of aspects of their lifestyle. This is definitely referring more to adolescents and the young adult. When risk-taking, as indicated, your frontal lobe only finishes maturing around about 25. So risk-taking is a big thing in adolescents and young adults. And we need to counsel for our patients and our survivors about this. Inactivity. Unfortunately, again, in questioning my people on the tall boat adventure cruise, the activity was low. Only about 5 of the 17 children were actively participating in some kind of sports activity. And then nutrition. Again, inquiring on what the nutrition is, both what is good for you and what is bad for you. Understand the food components that improve health and that which is detrimental to health. I'm going to go over the guidelines of WCRF in a moment and other nutrition resources. But in our long-term follow-up clinics, these components of making sure that you have access to these guidelines that are widely and freely available. Important in the counseling is to involve the family and in partners to intervene in changing the diet where it should be, intervening in obesity, intervening in encouraging activity. Nobody can do these things by themselves. You do need family, partners, and support groups to help you lead the most healthy lifestyle that you can. And from the clinic's perspective, not just the long-term follow-up clinics, but through your GP or nurse practitioner, follow up from a nutritional and a survivorship counseling point of view can lead to better survivorship outcomes. So prevention. The World Cancer Research Fund, this is one of the major organizations in the worldwide that uses prevention as its major mission. It is trying to encourage many prevention strategies, and it's one of the few funds that actually promotes prevention research. And I use this as a thing that needs to be advocated, that prevention research, it gets less than 5% of cancer research dollars. Obviously, cancer treatment is really important, and researching for cancer treatment is good. But that old cliche saying, prevention is better than cure. As I've showed you, just preventing tobacco and preventing an inappropriate diet can lead to a prevention of nearly 2/3 of adult cancers. So prevention does require more research on what are the strategies we should be employing. We think we know what the strategy is, just eat properly, exercise more, and that it is. But how you do that needs and requires adequate search. This food, nutrition, physical activity, and the prevention of cancer is freely available. You just go onto the World Cancer Research Fund, and you can, and they will send it to you either electronically or by hard mail. So, what are the recommendations? Be a healthy weight. This is probably self-explanatory, but you want to keep a healthy range and avoid weight gain in adult. And therefore, back to that, to try and do this, you need to be looking from childhood the importance of a healthy weight gain. Indicated is that obese children become obese adults. You want to keep your weight as low as you can within the healthy range recommended. And as indicated, if you lose just some of the simple anthropometric measurements, weight and weight for height, calculating your BMI and your waist circumference, you can continue to access these bioimpedance scales that I refer to. They're quite easily obtainable. They only cost about $40, and that's something that you can assess yourself what your percentage fat is. And you always want to avoid weight gain and increasing waist circumference. But what is in your diet? We now know that fiber is a really important component of your diet for a variety of different reasons, but part of it is the prevention of colorectal cancer. And you need approximately 30 grams per day of fiber from food sources. These contain the whole grains, non-starchy vegetables, especially legumes such as beans and lentils. And having a high plant food-based diet of vegetables and fruits. This varies from 5 to 7 portions, and a portion is at least 400 grams of a variety of non-starchy fruit and vegetables. So a high diet, Mediterranean diet is one of them, which is often used as an example. Limit the consumption of fast foods and other processed foods high in fats, starches, or sugars. Most of the things that are packaged or tinned or bottled have components in them that are there for preservative. A processed food is something that usually contains a preservative. Nitrates of ox, for example, common in sausages. Those are leading to processed food. There's an old grandmother's story myth that if something doesn't go rotten within 5 days, then throw it away. So the consumption of processed foods high in fats, starches, and sugars, try and avoid it. These are one of the things you want to avoid. Now, this is controversial, but the point it's trying to state that it is much better to get your vitamin D through sunshine or through food, your calcium, your vitamin C, virtually all vitamin Bs through your intake of food. The reason for that is that some of these bioactive food supplements, of which supplements micronutrients are, work better in their natural environment. In other words, they're better absorbed. So, for example, turmeric and curcumin now comes in a supplement, but it's probably better to take it in the turmeric root itself and use the natural substance. So while supplements still have a place for the patients who are actually deficient or even insufficient, it is still better for all your supplements all those natural things that you are taking, to try and do it through the diet. This is an important aspect. Breastfeed your baby if you can. It is both good for mother and baby. The general recommendations from the World Health Organization that you preferably should exclusively breastfeed for 6 months if you can, and there should be no coercion in doing this, and then start to add other foods beyond the age of 6 months. There is no advantage of solely breastfeeding beyond 6 months, because you then again may become deficient in other components of a regular diet. But again, it is a potential cancer and chronic disease and acute disease prevention for breastfeeding your baby. Limit alcohol consumption. Again, sometimes a little bit controversial, but if you want to be a true preventer, it is best not to drink alcohol. Alcohol is associated with a number of different adult cancers, especially related to the gastrointestinal cancers from your mouth through to your colorectal cancer. Sugar. Sugar is considered the new smoking. It is probably so much evidence now that high sugar intake, which leads to obesity, is a preventative perspective, both for cancer and for other long-term chronic disease. Sodas, any type of soda, one Coke, I believe, contains approximately 8 teaspoons of sugar. So use water if you're thirsty, or unsweetened drinks. Again, the goal, do not consume sugar-sweetened drinks. This again is a little bit confusing. There has been backwards and forthwards about this, but the preponderance of evidence is an excessive consumption of red meat, and again processed meat, can lead to an increased prevalence of colorectal cancer. Red meat refers to beef, pork, and lamb, doesn't really include poultries. And the processed meat, the meat in itself can be in excess, but also the substances they add to the processed meat, which can be carcinogenic. And this refers to you. After a cancer diagnosis, follow these recommendations if you can. We are obviously cognizant that many of the cancers can impair your diet, can impair your absorption, can impair the quantity and quality of food that you can take in. But if you can consult with a registered dietitian to give you guidance that is individual to you, depending on your circumstances, please do so. All cancer survivors should receive nutritional care and guidance on physical activity with trained professionals. So nutritional care and physical activity care really, really is important in your well-being. Just going to briefly touch at the microbiome. For the last 10 years, we've been reading more and more about that. So what is your microbiome? Your microbiome are all the living organisms that live in your gut. Bacteria, some fungus, and even some viruses, they all live there. But especially the bacteria, which you live in synergism in. In other words, they are beneficial to you. For example, vitamin K, which is very necessary for your clotting process, for your making clots to stop you bleed. If you have an impaired microbiome, you may have a bleeding disorder because you may not be producing sufficient vitamin K via your gut bacteria. You have 10 times more bugs, bacteria in your gut than you have cells in your body. And it's not just only in your gut, you have them on your skin as well. But you have bacteria from your mouth right through to your rectum. And we live sometimes in symbiosis in advantage to us, and sometimes they can be pathological. And when your microbiome is not in normality, you can get an overgrowth of bad bugs, which can affect your status and can affect cancer pathogenesis and other comorbidities such as inflammatory bowel disorders. So you are living with a microbiome. The microbiome that now have been evaluated from high-income countries, from a Western diet, to those small populations that still exist called the hunter-gatherers. For example, what are called the Bushmen in Southern Africa. They have a completely different microbiome and a completely different spectrum of disease because that microbiome is partially protecting them. We also know that in a number of other autoimmune diseases, the microbiome can affect your inflammatory reaction and the importance of your immune system. We are also seeing now lots of adverts for probiotics. Probiotics do help if you are really depleted, but taking probiotics is not as important as the role of prebiotics. And prebiotics are your diet. It's the prebiotics that encourage the normal microbiome, the microbiome that is beneficial to you. It's the lentils, the vegetables, the fruits, the variety of different foods that you can take in that will allow more normal bugs to grow, your microbiome. So this is a really important component now. We're now even hearing about what's called fecal transplants, where people who had problems, inflammatory bowel problems in oncology, we often see patients who have been on antibiotics the last time, and a long-term antibiotic program can result in killing many of your microbiomes and the resulting overgrowth of Clostridium difficile, which causes diarrhea and a painful gut. So probiotics and changing that it can be an important treatment, of which a fecal transplant are now being used as treatment of that kind of problem. So read more about the microbiome. I think it is something that we're going to hear more and more about, and will be playing a part of our supportive care in the treatment of oncology patients. So in conclusion, I hope I've convinced you that nutritional assessment and counselling should be an ongoing and fundamental component of any long-term follow-up, either within an organised clinic or by your GP or by your nurse practitioner or nurse clinician, and by yourselves as well. It has the intentional impact of improving your quality of life, your well-being, how satisfied you feel. It does have the potential impact to ameliorate, decrease some of the long-term side effect of cancer therapies. Again, I'll reiterate, for those people who have cardiac disease, having an adequate diet and becoming an adequate diet can ameliorate, decrease some of that cardiac problems that so many of our patients may see in later life. And the potential impact of nutrition on prevention of adult cancers and other chronic, non-communicable chronic diseases. We can improve our life duration and quality by improving our nutrition and thinking of it as a preventative component of our lifestyle. I hope I've convinced you that it is an aspect of cancer control, from prevention through to palliation and all those other components of the cancer journey. And we should be evaluating and embedding research into our long-term research clinics to find appropriate strategies to help prevent and improve quality of life of our survivors. I would like to acknowledge our nutrition network at CEOP, which we established 4 years ago. And we published our first nutritional supplement in pediatric blood and cancer, which have 7 articles all on nutrition, of which the one that may be of most interest to you, as it's still, as say, relevant to adult cancers, is Nutritional Concerns of Survivors of Childhood Cancer, a first world perspective, lead author Jennifer Cohen. There's also in the Journal of National Cancer Monographs, a very good journal, related to obesity and the ramifications of obesity in patients with cancer. This is our publication. This was co-edited by myself and Dr. Ronnie Barr from McMaster. And this is a statement I'll end up with saying from Meryl Streep. It's bizarre that the produce manager is more important to my children's health than the pediatrician. This is contacts within our nutritional network, if you would wish to do so, and also for the Canadian Cancer Survivor Network, who are sponsoring this presentation, who are doing great work. Please contact them more if you wish to. And I believe this is going to be available for those people who weren't able to join into this talk. Thank you, and I'm happy to answer questions.
Great, thank you so much, Dr. Rogers, for that presentation. We have several questions in the chat. If you do have to leave right away, let me know and we'll stop the questions there. But here's the first question. How can one balance the need for minerals and vitamins when certain treatments recommend or insist that you not take certain treatments? For example, no calcium supplementation on some TKIs.
Again, the important part is try and eat what is most appropriate in a balanced diet. The reason why this is being stated by your oncologist is the fact that antioxidants, of which vitamin C, zinc, these are all antioxidants. They can directly affect some of the chemotherapy that is given to you, which is based on a toxic effect of oxidative damage to the cancer cells. So what is generally stated is specifically the antioxidants should not be given during the period that you are receiving chemotherapy. The rest is trying to attain an adequate mixed diet through food substances as opposed to taking supplements.
Next question. Can telomeres be lengthened through diet? I have uveal melanoma and monosomy 3 and trying to eat as healthy as possible.
This is an interesting question, which I don't really have an answer for. Your telomeres in a general normal life are going to get short naturally. We all have our given span of life. However, there does appear to be toxic substances that may shorten telomeres, but knowing what can prevent that is still being studied.
Next question. Does celiac disease relate to cancer at all?
Sorry, repeat the question.
Does celiac disease relate to cancer?
Unclear. I haven't seen strong evidence that it does. Celiac disease is, as you know, an autoimmune disease, and some autoimmune diseases are related to increased lymphomas. But directly, it may do, it is being studied, but I can't give you a definitive answer at this point.
Next question, are fermented foods considered prebiotics, and is this category of food good for our microbiome?
Prebiotics are definitely valuable to your microbiome. Having an adequate microbiome and prevention of cancer does appear to be true, especially in those patients who are at high risk of colon cancer, colorectal cancer. So a diet that is high in prebiotic is recommended.
Next question, also related to prebiotics. I'm on Revlimid, which lowers all blood counts on purpose so that the bad multiple myeloma cells don't grow. Does that mean I should be avoiding prebiotics?
I have not seen anything written that avoiding prebiotics is a cancer treatment or preventative strategy. I'd be interested to know if there was, but no. Prebiotics generally is an effective way of improving your microbiome, and improving your microbiome may act as a preventive strategy.
Next question, are there any dietary changes that can be made to improve neutrophils and leukocytes that have been depleted as a result of cancer treatment?
Unfortunately, to my knowledge, the answer is no. Having an adequate diet does improve your overall immune system. In other words, I've alluded to the importance of vitamin D, the importance of zinc. These are all enhance your immune system, but they are unlikely to encourage a response of your neutrophils after chemotherapy when you're going through that neutropenic period.
Next question, what is the best way to find a healthcare practitioner that is also well-versed in cancer nutrition?
Basically through the cancer agencies of Canada. For example, BC Cancer Agency in British Columbia, there are dietitians that will give advice on nutrition, and they have support groups around that, especially for colorectal cancer. So communicating with the cancer control organization within the province you live and asking for them. Again, the Cancer Control Agency, it has a website which has components of supportive care, which is open to the public. In fact, all the protocols that are used for treatment are open to the public from the BC Cancer Agency website. And on that, they have a component of diet support on treatment and off treatment.
Next question. Are there specific diets for specific cancers and or mutations, fusions within a type of cancer?
Are there specific diet for specific cancers? Is that the question?
Yes.
There are components of diets that may be specific dependent on what other underlying morbidities the patient has. So for example, a patient who's got underlying inflammatory bowel disease should probably stick to a specific diet. But again, I reiterate the importance of a well-balanced diet, making sure that you're not micronutrient deficient and making sure that you get appropriate fiber, making sure that you're not getting too much or too little calories or too little protein. A well-balanced diet is the most specific diet you should be trying to use when you are under treatment and a survivor of cancer.
And I think this will be the last question for today. How do you view the practical integration of nutrition and exercise counseling in a clinical setting in the future?
Education, 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 advocacy, advocacy, advocacy. You know, as I indicated, I think nutrition is not paid enough attention to in that whole of that cancer control spectrum that I alluded to. And we need more advocacy about having registered dietitian at our clinics. For example, at my children's hospital in Vancouver, we have a big cancer clinic, and we only have 2 dietitians, even though we've fought and screamed and shouted the need for adequate nutritional counseling. We don't, in fact, even have a nutrition dietitian allocated to our long-term follow-up clinic. We can only use them for specific referrals. So there is a need for advocacy about nutrition, support, counseling, and nutrition research. So you, our patients, our survivors, you are the best people to advocate for the necessity of this.
Great. Thank you so much again for hosting today's webinar and for your very insightful presentation. And thank you everybody for attending and joining us today.